Yes,
Am I audible?
yes, sir.
Okay. Today we'll discuss about basics of movement disorders. Okay. Good afternoon to everyone. First, we'll define what is a movement disorder. Next slide. Movement disorders can be defined as neurological syndrome in which there is either an excess of movement or paucity of voluntary and automatic movements. It can be hypokinetic or hyperkinetic movement disorders, but patient should not have any weakness or spasticity, which was defined by Sir William Osler. So we'll go through the basic pathophysiology of movement disorder. As all of you know, basal ganglia circuit is an indirect pathway. Direct pathway is like motor switch. If it get activated, it will leads to the motor movement. Any diseases that are affecting the direct pathway, that will leads to hypokinetic movement disorders like Parkinsonism. And indirect pathway, mainly net effect would be inhibition of motor cortex. So any diseases that is affecting the indirect pathway, that will causes hyperkinetic movement disorder. Okay. Basic final output would be thalamus to motor cortex. If any pathways which are inhibiting the thalamus, that will leads to the decrement of motor activity. So any pathways which are activating the thalamic function, that will leads to positive motor activity. Say for example, thalamus is the final relay station, globus pallidus is the switch. If switch get activated, it will inhibit the thalamus, so motor net activities will be completely improved. So in case of indirect pathway, the subthalamic nuclei which will get activate the globus pallidus, that will leads to the that will leads to the thalamic dysfunction. So that will leads to hypokinetic movement. So whenever the disease that is affecting the direct pathway, so from the striatum, globus pallidus, thalamus, and the motor cortex, it will be direct pathway. From the motor cortex, striatum, subthalamic nucleus, globus pallidus, thalamus, and motor cortex will be indirect pathway. The diseases which are affecting the direct pathway, that will leads to the hypokinetic movement disorder, and the diseases that are affecting the indirect pathway, that will leads to hyperkinetic. The thalamus and motor cortex will be the last relay station, and globus pallidus interna and substantia nigra would be the, it will act as a switch. Okay. Next. So just you remember the name. The indirect pathway, mainly motor cortex, striatum, globus pallidus internus, and thalamus. In an indirect pathway, motor cortex, striatum, globus pallidus externus, subthalamic nucleus, and globus pallidus internus and thalamus. Okay, just you remember the name. The basic concept would be direct pathway is activation of the movement, indirect pathway is inactivation of the movement. So diseases that are affecting the direct pathway, that will leads to hypokinetic movement disorders, and the diseases that are affecting the indirect pathway, that will leads to hyperkinetic movement disorders. Okay, next slide. So basic pathogenesis, it may be some little like from the metabolic parameters to degenerative diseases, sometimes hyponatremia, hypomagnesemia, hypermagnesemia, calcium metabolism disorders, that do also causes movement disorders. Sometimes the degenerative diseases like synucleinopathies also causes movement disorders. Say for an example, in a synucleinopathies cases, synucleinopathies are nothing but infiltration of a synuclein protein in the various neuronal structures, as seen in Parkinsonism. So if the disease part that is involving the lower brainstem, that will leads to the olfactory loss, constipation, gastrourinary symptoms, and orthostatic hypotension. The diseases that are involving the lower or middle brainstem, that is pons and medulla, that will leads to REM behavioral disorders, excessive sleepiness, depression, anxiety, and cognitive changes. And if a disease part involving the midbrain, that is substantia nigra, that will leads to Parkinsonism features. If diffuse cortical involvement is there, that will cause neuropsychiatric symptoms along with the cortical symptom. The spectrum will rises from the brainstem to cortex or whole diffuse cortex. So initial pathology will start with the some part of the cerebral cortex. As the disease progresses, it will used to include all the cerebral cortex parts. So patient initially will have mild olfactory symptom, mild constipation. As you see in Parkinson's disease, initial patient will have only olfactory dysfunction and constipation. As the disease go on progresses, that will leads to REM behavioral disorders, depression, Parkinsonism, and if it is in end stage, that will lead to cortical dysfunctions like neuropsychiatric complication will occur. Just you remember what are all the synucleinopathies and what are the parts which are affected in various Parkinson disease. Parkinsonism I will discuss in the next or next to the next class. Okay, this is the basic concept of pathogenesis. So most of these degenerative disorders may be secondary to unfolding proteins or any genetic mutation, because all of these degenerative diseases associated with the movement disorder, like say for example amyotrophic lateral sclerosis will be associated with the fasciculation. Frontotemporal dementia is also associated with motor neuron diseases. Semantic dementia, frontotemporal dementia, progressive aphasia is also associated with movement disorders. And corticobasal degeneration, it will causes alien limb phenomena and myoclonic jerks. Progressive supranuclear palsy, that will cause a supranuclear gaze palsies, axial rigidity. And in Alzheimer's disease, late stage of Alzheimer's disease, patient will have myoclonic jerks, seizures. Okay, so CZD, Creutzfeldt-Jacobs disease, patient will have myoclonus and cognitive decline. So entire spectrum like varies from simple protein accumulation to genetic mutation. So all of these degenerative diseases are associated with the movement disorders. Okay. So let us come to the anatomical localization. Various brain structures which involve in the movement disorders, like any diseases that is involving the substantia nigra, particularly pars compacta, that will result in Parkinson's disease. If subthalamic nucleus is involved, causes Balismus. Caudate nucleus predominantly causes chorea. Putamen will be affected in dystonia. Essential tremors, cerebellum. Rubral tremor is also called Holmes tremor or midbrain tremor. It is secondary to involvement of dentato-rubrothalamic fibers. Just you remember the name and the localization. Say for example, if patient is having Parkinson's feature, so you can localize into anatomical localization will be substantia nigra. Balism is there, subthalamic nucleus will be involved. Like that, depending on the clinical phenotype, you can anatomically localize the site of involvement. Next slide. In a case of tremors and tics, there are multiple localization will be there. Tremors will not confine to only basal ganglia due to involvement of nigrostriatal pathway or midbrain or any involvement of the cerebellum also causes tremors. And tics also multiple localization are there. For myoclonus also wide varieties of sites are there, because brain, cerebral cortex, subcortical, spinal cord, and even peripheral involvement also causes myoclonus. These three will have different localization, but Parkinsonism, chorea, Balism, dystonia will have appropriate anatomical localization. But tremors, tics, and myoclonus will have like not like localized one disease, like one localization, one anatomical localization, and one disease will not be there. Okay, multiple sites will be involved in these kind of movement disorders. So for every movement disorder, whenever you see the patient, first you have to identify what movement patient is having. Say for example, if a patient comes idiopathic Parkinson's disease, you have seen a number of cases. In idiopathic Parkinson's disease, movements will be rigidity, tremors, and bradykinesias will be there. These are the individual movement. Syndrome recognition, it will come under the umbrella term of hypokinetic disorders. And third step is disease recognition. It will be done by ruling out the other mimickers like typical Parkinson's and atypical Parkinson's. Atypical Parkinsonism will have like autonomic dysfunction, urinary complaints, postural instability, recurrent fall. And typical Parkinson's disease will have asymmetrical rest tremors, slow progression. So third step would be which disease patient is having. Like idiopathic Parkinson's disease, the disease recognition syndrome is hypokinetic, and movements which are involved will be tremors, rigidity, and bradykinesia. So every movement disorders, you need to go step by step. So for whenever you are defining the movement, so you need to follow these rules. Okay, so you should mention all these following mentioned points: speed, whether that movement is fast or slow; amplitude, rhythmicity, duration, and body parts, which body part is affected; distribution of the movements, what kind of pattern the movement is following, whether it is stereotyped or flowing, continuous or intermittent or paroxysmal. Movements are whether simple or complex, whether any aggravating or relieving factors, and whether patient can able to suppress the movement or not. All those things to be mentioned. So whenever you put in a particular group, so you can diagnose the condition. So whenever you're writing the movement in a history or any examination, you should follow all this pattern. Okay. So along with the whenever you're taking the history, you need to ask for which are the symptoms, with all the neuroaxis are involved, whether only cortical symptoms are there, subcortical symptoms are there, you need to mention in the history. Like what type, whether it is infection, inflammatory condition, or descento condition. So class of movement, whether it is hypo or hyperkinetic, any family history is there or not, any birth or developmental abnormalities, any past history of trauma or encephalitis, whether any past history of any antipsychotic drugs or dopamine supplementation, focal deficit in the neurological examination, and what all the general physical examination findings. In the next class, I will tell about the general physical examination, history taking, and examination finding in the movement disorder. That next class will discuss about these examination findings, okay, and whatever the final laboratory investigation you get. So all those things to be mentioned, okay. So let us come to the introduction about the movement disorders. Major categories would be hyperkinetic and hypokinetic, and you can classify as a primary and secondary movement disorder also. In hyperkinetic movement disorders, patient will be having excessive, repetitive, involuntary movement that intrude into the normal flow of motor activity. These includes chorea, dystonia, myoclonus, stereotypes, tics, and tremor. In hypokinetic movement disorder, it will patient will be having either akinesia, that is lack of movement, hypokinesia, that is reduced amplitude of movement, or bradykinesia, that is slowness of the movement, and rigidity will be there. Either one, if a patient having among these four symptoms, if patient having one symptom also, you can classify under hypokinetic movement disorder. Typical examples would be Parkinsonism, okay. So as I told earlier, primary is where you don't get any particular cause, more related to the genetic or any neurotransmitter related diseases. In secondary, you may get like structural, toxic, metabolic, any vascular causes that are leading to the movement disorders, okay. You can classify like this also. Let's come to the examples. There are multiple examples for hypo and hyperkinesia. For MD medicine student, I think few of the examples are enough, okay. Akinesia, bradykinesia, apraxia, blacking hole tics. These are nothing but tics with some impaired awareness, predominantly seen in pediatric case group, can be differentiated from the focal impaired seizures by asking the history of urge and suppressibility. Cataplexy and drop attacks, catatonia, psychomotor depression, OCD that is leading to the slowness, freezing phenomenon, hesitant gait, hypothyroid slowness, rigidity, stiff muscles, all will come under hypokinetic movement disorders, okay. Next slide. In hyperkinesia, so many examples are there. Dyskinesias, akathisia, ataxia, athetosis, balism, chorea, dystonia, hemifacial spasm, hypereclepsia. Hypereclepsia is nothing but hereditary condition in which exaggerated physiological starter will be there. Hypnagogic dyskinesias, jumping disorder, again it's also physiological exaggeration of the startle. Jumpy stumps is nothing but sometime post amputation patient will have abnormal movement involving that amputated limb, that is called jumpy stumps, okay. Painful moving toes and finger syndrome, myoclonus, myokymia, synkinesis, myoarrhythmias, paroxysmal dyskinesias, periodic movement disorders in the sleep, especially REM sleep disorders, restless leg syndrome, stereotypy, tics, and tremors. The points which that I have highlighted are important for your exams or clinical case discussion, okay. What are the points that I have highlighted in this triangle? These are important for MD medicine students, okay. So some patient will have mixed movement disorders, not like typical hypokinetic or typical hyperkinetic. Both hypo and hyperkinetic movement disorder will be there in some disease entities. Like say for an example, in multiple system atrophy, patient will have myoclonus and Parkinsonism. In corticobasal degeneration, patient will be having Parkinsonism, myoclonus, and asymmetrical rigidity. In Huntington disease, patient will be having chorea, dystonia, Parkinsonism. In primary dystonias, patient will dystonia with dystonic tremors. Wilson's disease patient will be having tremors, dystonia, and Parkinsonism. And in mitochondrial diseases and progressive myoclonic epilepsy, celiac disease, patient will have ataxia and myoclonus. So these will be categorized under mixed movement disorders. Okay. Till now, any doubts? You can ask. Any doubts?
No, sir.
Okay, we'll go. We'll come to the hypokinetic disorders. Okay, first one is akinesia or bradykinesia. Akinesia refers to the complete absence of movements. Bradykinesia refers to the slowness of the movement. Hypokinesia refers to the decreased amplitude of movement. All these terms grouped together and referred to as bradykinesia. It is a major important diagnostic criteria for every Parkinsonism. If you want to say patient is having Parkinsonism, patient must have bradykinesia. Okay. Other associated features also we can add it, but bradykinesia should be there. Okay. This is classified like for diagnostic criteria. We use UK Parkinson's Disease Society brain bank criteria, in which bradykinesia is the major including point. Okay. Second one is catatonia. Catatonia, it is like classified. It is the catatonic patient will be having catalepsy, that is abnormal maintenance of the posture or physical attitude, and waxy flexibility, like retention of the limbs for a prolonged period, indefinite period in which they earlier placed. Negativism, mutism, and bizarre mannerisms will also be there. Patient with catatonia will remain in a one position for hours, moves exceedingly slowly to commands, usually requiring the examiner to push them along with that. However, when moving spontaneously, they can move quickly. That will help to differentiate from other movement disorders. You might have seen many cases in emergencies and psychiatry ward also. Okay. Second one is psychomotor depression. In a patient with depression, also sometimes have gross retardation of the movement. That is called psychomotor retardation. Very important to differentiate from hypokinetic movement disorders, because management would be entirely different and evaluation also entirely different. So in a patient with depression having these kind of slow movements, you need to ask for other associated depression features. And most of the patient, those who are having depression, will have associated psychiatric illness, more commonly vegetative symptoms like sleep disturbances, eating disturbances, weight gain, all those things associated vegetative symptoms will be there. And the symptoms of hopelessness, worthlessness, and suicidal tendencies will also be there. So if the patient is having these kind of psychomotor retardation along with these complaints, you can label it under depression. Sometimes OCD, that is obsessive compulsive disorder patient, will also have these kind of psychomotor retardation. Sometimes, most of the time, you may not able to differentiate from the hypokinetic movement disorders. So because patient have difficulty in initiating the goal directed movements, and on examination sometimes you may get cogwheel rigidity, decreased arm swing, and decreased spontaneous movement, hypomimia. So in that setting, you need to see for bradykinesia, and you need to see for micrographia, tremors, and freezing episodes. Usually these things will not be affected in OCD, but in hypokinetic disorders, patient will have bradykinesia, micrographia, freezing episodes, and there will be loss of postural reflexes. Loss of postural reflexes can be tested by full test. Okay, we'll discuss in the examination part. Okay. So next come to the freezing. This is a phenomena in which transient periods patient will not able to do any motor activities, being stuck in a place. Say for example, some patient will have starting hesitation, like freezes when gate is initiated. Sometimes patient will have turning hesitation, destination hesitation. Sometimes like obstacles may causes the freezing episodes. Sometimes while entering the hall, leaving the hall, that also causes the freezing episodes. Transient freezing of the speech will also be there. Palilalia will be there, and freezing episodes also affect the speech. Sometimes apraxia of speech also termed under freezing. Okay, these are the few examples for freezing episode classically seen in hypokinetic movement disorders, in especially Parkinson's. Okay. Next, come to the hesitant gait. And as the age progresses, due to defect in the proprioceptive mechanism, patient sometimes walk very cautiously, like as if walking on the ice pack gait. This is called ice pack gait also. This is hesitant gait, most commonly seen in elderly, because they have tendency, like patient may conscious due to anxiety that he would fall. Okay. So clinical features, so whenever you are examining the hypokinetic patient, or whenever you are taking the history of hypokinetic syndrome, you need to ask for bradykinesia. History also you can ask whether the slowness of activities there or not, any tightness of the limbs are there, and tightness of limbs are there or not, gait disturbance is there, or tremors, ataxia, any autonomic dysfunctions, cognitive dysfunctions, speech difficulties, dysphasias, dystonia, eyelid opening difficulties, apraxias, any associated signs and symptoms of motor neuron diseases. myoclonus, neuropathy, oculomotor deficit, sleep impairment, or any dopamine responsive, dopa response, family history of similar movement disorders. All these will be helpful to differentiate from the Parkinson's disease, progressive supranuclear palsy, multiple system atrophy, C&P, corticobasal syndrome, and Lewy body dementia. So these are the clinical feature you need to ask, and you need to correlate with the various hypokinetic disorders so that you can come to the clinical conclusion. Because most of the degenerative diseases, we don't get any positive investigation findings unless if you go for higher end investigation like functional MRI, PET scan. In that cases we can make out, but in our setting it is very difficult to get all those investigations. So in that setting, if you ask proper history and if you do examination, most of the time you can make the diagnosis whether the patient is having what kind of Parkinson's, like whether the patient is having typical Parkinson's symptoms or atypical Parkinson's. The typical Parkinson's disease will be your idiopathic Parkinson's disease, that is Parkinson's disease. And the atypical Parkinson's, all those will come under like PSP, MSA, CBS, or Lewy body dementia will have atypical Parkinson's disease. Okay, these we'll discuss in the subsequent classes. So sometimes hypothyroid slowness also mimics as hypokinetic movement disorders. Most of the resident you might have seen a number of cases of hypothyroidism. The isolated the hypothyroid patient will have associated complaints like slow metabolic rate, bradycardias, whole body temperatures, myxedema, hair loss, hoarseness, effusions. All those associated symptoms will help you to differentiate from the typical Parkinson's syndrome. So you need to see for hypothyroid also. Okay, whenever you are seeing the Parkinson's disease or hypokinetic movement disorder, you need to check always for hypothyroidism. So let's come to the stiff muscles. Due to the continuous activation of the muscle motor neuron activity, that will leads to muscle firing, that will causes the stiffness of the muscle. Predominantly it will affect the paraspinal muscles, so that will leads to the exaggerated of lumbar lordosis, back pain, and stiffness. These stiffness disorders, as an example, stiff person syndrome, stiff limb syndrome, progressive encephalomyelitis with the result PERM syndrome, all will come under stiff muscle syndromes. Okay, just you remember the name. Okay, stiff muscles and conditions mimicking condition that are associated with the stiff muscles. Okay, let us come to the hyperkinesias. Okay, we'll discuss one by one. Hyperkinetic movement or movement disorders, you need to ask or you need to see for whether movements are flowing in nature or not. If flowing natures, you need to see for either high amplitude movements or low amplitude movements, a high amplitude or low amplitude. Most of the time chorea movements will have small amplitude and balism will have large amplitude because of involvement of proximal joint also. Okay, if jerk, shock like movements are there, that indirectly indicate myoclonic movement. If rhythmic to and fro motions are there, it will be tremor. If sustained postures or sensory tricks, that again indicates dystonia. If a movements are stereotypic, often sometimes distractible by any touch or verbal stimuli, it will be seen in stereotyping. If the stereotypic movements which are suppressible or any urge to move the movement, that you can classify under tics. Okay, this is the basic concept. So whenever you are taking the history or whenever you're commenting the movement disorder, you need to mention whether the movements are flowing or non-flowing, large amplitude, small amplitude, whether jerky or non-jerky, rhythmic or non-rhythmic, whether it are having any posture and change in the posture, can be distractible, suppressible, or any urge to movement. All those things, if you ask the history properly, you can diagnose the condition. Okay, you can particularly make out which movement disorder patient is having. Okay, this is again, it is the same slide. Most of the movement disorders are intermediate range. The regular movement disorders will be tremor, balism, and palatal myoclonus. And unpredictable fleeting movements will be fasciculation, myoclonus, chorea, and dyskinesis. In between, all the movement disorders will come. Okay. Next, let us discuss one by one. Dyskinesis is nothing but it is also a hyperkinetic movement disorder in which patient having complex involuntary movement. Let's say, for example, patient will have mixed movement, chorea, dystonia, tremors, all mixed movement in a single person. That is called as dyskinesis. Okay. Most commonly we see secondary to adverse drug effects. Say, for example, if a patient taking long-standing antipsychotic drugs or if a patient taking long-standing dopamine and levodopa agonist, that will causes dyskinetic movement disorders. Okay, some dyskinesias are defined as paroxysmal when they occur infrequently or intermittently. Okay, this we'll discuss in the next slide. Next one is akathisia. The literal meaning would be unable to sit still. Patient will have feeling of inner general restlessness that is reduced or relieved by moving about. The patient will be having symptoms of like akathetic patient. When they sit, they will sit with the cross. They will sit. Sometimes they will cross the leg, uncross the legs, rocking movement of the trunk, twisting movement of the limbs, and they sometimes get out from the chair and they walk. Even they make sometimes noise like moaning. Carrying these motor activity that will bring the patient relief. So that's why keep on patient will be doing these kind of abnormal movement. Sometimes these movements also stereotype, and the repeated movements will do occur. Okay. And ataxia, as all of you know, this is like inability to maintain, inability to perform the coordinated voluntary motor activities in spite of normal power. Okay. So cardinal symptoms would be dysmetria. In dysmetria, again, you can classify it as hypometria, hypermetria. Hypermetria, there will be overshooting will be there. In hypometria, undershooting will be there. Okay, ataxia chapter will discuss in detail. Okay, just ataxia, it will come under hyperkinetic momentum. Just you remember. Okay. Next, come to the athetosis. It is a slow, breathing, continuous involuntary movement. Initially, the name coined in the early part, kernicterus patient, prenatal insult, secondary to hyperbilirubinemia. Most of the patient having writhing, slow, continuous movement. Okay, initial term that was coined in the pediatric age group. Most oftenly, it affects the distal part of the body, but axial musculature also involved. When sometimes these movements may not present at rest. By doing the voluntary motor activities or speaking also induces the movements. Okay. Most of the time it will associated with chorea, that is also called chorea athetosis. Sometimes it may associated with dystonia also. Okay. This is the same slide, I think. You need to another terminology is called pseudoathetosis. Most commonly you see in loss fiber neuropathy. It is secondary to loss of proprioception. Patient will be having abnormal athetoid movements in the distal extremities involving the fingers and toes. Associated symptoms like tingling, burning, ataxia, wash basin phenomena, all those things will help you to differentiate from athetosis and pseudoathetosis. These pseudoathetosis will be predominantly seen whenever patient closes the eyes. Okay. Next, come to balism. It is also chorea that is involving the proximal parts of the limb that will result large amplitude of movement. Patient will have flinging, flailing. Sometimes patient having kicking movements also. Okay. So most oftenly we see unilaterally. This is called hemibalism. Sometimes bilateral upper limb or bilateral lower limb may also involve. That is called bibalism. Most oftenly we see basal ganglia lesion. In your medical emergency, you might have seen that is secondary to non-ketotic hyperglycemia that is involving the basal ganglia circuit. Patient will present with hemibalism, hemichorea syndrome. Okay. Next, come to the chorea. Chorea is nothing but involuntary, irregular, purposeless, non-rhythmic, abrupt, rapid, unsustained movement often flow from one part of the body to another part of the body. These are very unpredictable movement in the direction, timings, and distribution. And random flowing movement will be sometimes it may affect proximal, distal, one limb and another limb. So these are all involuntary, non-rhythmic, rapid, abrupt onset flowing movements that are involving the multiple body parts. Okay. So depending on in distribution of chorea, we can make out a few diagnoses. In Huntington disease, most commonly chorea involve facial muscles and the forehead muscles. Orobuccolingual chorea, most commonly we see drug-induced paraneoplastic syndrome, chorea acanthosis, Leishman syndrome, Wilson's disease. Okay. In hemichorea, most commonly we see basal ganglia strokes, non-ketotic hyperglycemia, infections like toxoplasma, and Sydenham chorias, paraneoplastic syndrome, and CZD variants also we can see hemibalism, hemichoria. Okay. So let us come to the approach. If a patient is having choria, you rule out like in physiological, like early infancy and the later part senile choria will come appear in the early infancy, and as the age progresses, it will get disappear. Okay. Whenever you are dealing with the organic choria, you need to again classified as non-benign and benign. Benign hereditary choria, it is seen in pediatric age group less than 10 years. As the age progresses, again it will also, the symptomatically patient will improve. Let us come to the non-benign variety. It is again classified as genetic causes, congenital cerebral palsy related or acquired causes. In genetic causes, ataxia, telangiectasia, Wilson's disease, Huntington's disease, parperia will causes choria. In congenital disease like cerebral palsy, patient will have choria. In acquired diseases, most commonly we seen drug-induced choria like levodopa, rheumatic fever infection, Henox-Colon purpura, SLE, vasculitis, endocrinopathies, kernictures, parathyroid illnesses, vascular malformations, malignancies, thyrotoxicosis, and post-traumatic. These are the acquired causes. So depending on the history examination, we can come to the conclusion. Okay. So this is the flowchart. Just you go through whenever you get the free time. So in the history, what are the things we need to ask? And neurological examination, what we have to do? What are the laboratory tests we have to advise the patient depending on the history and examination. Like we plan one class for chorea, myoclonus, tremors. We'll plan one single class better. Okay, rather than telling all these movement disorders in detail in a basic class, it would not be good. Okay, next. Next, come to the dystonia. This is the sustained movement upon repetitive associated with twisting movements. Sometimes, most of the time, it will lead to abnormal posturing of the body. Okay. These movements are repeatedly involve the same group of muscles. So in chorea, there will be flowing movement. Sometimes it may involve proximal, distal. There will be flowing movement in chorea that will help to differentiate from the dystonia. It is secondary to activation or co-contraction of both agonist and antagonist muscle that is leading to the posturing of the joint. Okay. It may be sometimes these dystonic movement will be associated with athetosis, like that will lead to slow movement, athetotic dystonia, and sometimes it will be associated with the myoclonus that will lead to shock-like or jerky movement that is called myoclonic dystonias. Duration, sometimes it is less than seconds, that is called dystonic spasm. Several seconds to minute, that is dystonic movements. Sometimes it will progress for minutes to hour, that will lead to dystonic posture for a prolonged period. So classical clinical symptom will be sensory tricks. Say for example, see the picture on the left side, the patient having cervical dystonia, left lateral colis. To prevent that, patient put her hands to the chin. And below mentioned diagram, patient have cervical dystonia. To prevent that abnormal movement, patient had put the fingers on cheek and chin also. So these are called sensory tricks, gestus antagonist. This is a very classical features of dystonia. So if a patient is having these sensory tricks, you can indirectly diagnose as dystonia only. This is a very classical part. So by this sensory stimulation usually reduces the movement, that is tactile or proprioceptive stimulus reduces the dystonic movement, so that patient used to acquire these kind of sensory tricks. So this is the classical picture, don't forget this. Okay, let's come to the few examples. In the picture A, patient having that oromandibular dystonia, A and B, oromandibular dystonia. C is jaw opening dystonia, and D is cervical dystonia of lateral colis. And E, patient put some scarf behind the scalp to prevent the abnormal movement of the head. And F is patient is having lateral flexion, that is scoliotic lateral flexion movement. This is called PISA syndrome. And G is truncal dystonia, retrocolis is there, segmental dystonia is there. And H is patient is having blepharospasm, it is a part of Meek syndrome. And I and J, patient is having hemifacial spasm. And in a K, patient is having hand dystonia. And L, patient is having this is task specific dystonia. Whenever writing, patient is having dystonia, that is called writer's cramp or task specific dystonia. Whenever using the violin, patient is having dystonia. That is also called task specific dystonias. And figure N is patient is having persistent dorsiflexion of the foot dystonia, and DO also patient is having left foot dystonias. Okay, these are just imaging findings of dystonia. Okay, so whenever patient is having dystonia, just you rule out pseudo dystonia, because sometimes like stiff person syndrome, Isaac syndrome, Satoshi syndrome. In Satoshi syndrome, patient is having GI symptoms and tremors. Okay, that also sometimes looks like dystonic movement. These all come under pseudo dystonias. And psychogenic dystonias should also be ruled out. Like psychogenic movement disorder, I will tell in the last slide. Okay, in organic dystonia, you classify according to the age, according to the site of distribution, according to the cause or etiological agent. Primary dystonia, it is most oftenly secondary to the genetic mutations or any sporadic mutations. It is classified as focal dystonia. Focal means only single part of the body. Segmental means adjacent, more than one part of the body, but both should be in a segment, in a continuous manner. Multifocal means different part of the body. Generalized means different part of the body along with involvement of the trunk. That is called generalized dystonias. Okay, just you remember the name. Focal, one part. Segmental is consecutive part. Multifocal is involvement of multiple parts of the body. Say, for example, patient is having bilateral upper limb, that is multifocal. In a right upper limb, two segments, that is segmental. In a right upper limb, only one segment, that is focal. If a patient is having the truncal dystonia along with the multifocal dystonia, that is called generalized dystonia. Sometimes secondary structural lesions of the brain also causes dystonias. And dystonia plus syndrome, like the patient by any having inheritance, like can you go back to the slide? If a patient having genetic mutations like responsive dopamine responsive dystonia myoclonus syndrome, that is DYT spectrum disorders. These are the dystonias which are secondary to genetic mutations. And if a patient is having autosomal recessive inheritance having the dystonia like dopa responsive dystonias, just you remember the name for autosomal recessive dopa responsive dystonias, autosomal dominant, that is DYT associated with the gene, and some of the dopamine responsive dystonias will come under also in the autosomal dominant inheritance. Okay. So when you have to evaluate the dystonia, most oftenly we don't get the cause. These all come under the primary dystonia or idiopathic dystonia. So when to suspect or when to evaluate the dystonia? If a patient is having possible history of any head trauma, encephalitis, toxin exposure, or perinatal insult associated with other neuroaxial involvement like dementia, seizures, or any focal neurological deficit whenever you are doing the examination. If the patient is having dystonia at rest also, most of the dystonias will disappear or attenuate under rest, but the secondary dystonias will worsen with the rest, or these will come under the secondary dystonias. If a early involvement of craniobulbar symptoms, if a patient is having any hemidystonia, if you get any imaging done or laboratory workup that is showing abnormal findings, so in that setting, all these features will come under secondary dystonia, because there are very treatable condition. You need to identify if a patient is having red flag of these mentioned point, you need to evaluate in detail. Next slide, that is hemifacial spasm due to the hepatic activation of the facial innervated muscles, same as that of trigeminal neuralgia. Facial muscles, if the facial nerve get activated or any increase in the neurotransmission or any increase in the hepatic transmission, that will lead to abnormal contraction of the facial muscles. Most oftenly you see due to the vascular loop that is compressing the facial nerve, that will also causes hemifacial spasm. Patient will be having symptoms involving the both upper and lower part of the face, involving the orbicularis, oris, oculi, or hemifacial involvement will be there. Patient will have jerky movements. This can be classified under myoclonus also. Facial spasm under the heading of myoclonus also we can classify. Patient will have jerky movements that are involving the upper and lower half of the face. Okay. So next come to the periodic movement disorders in the sleep. So periodic movement of the sleep and hypnagogic dyskinesias all will come under the single umbrella term. Rather than discussing all, better we'll discuss the one entity that is called REM, sleep behavioral disorders. REM is rapid eye movement, as all of you know. The REM, sleep behavioral disorder, that is RBD, is very important. You should be knowing the basic concept of REMBD. As all of you know, during the REM sleep, patient will be having atonia. It is usually regulated by locus coeruleus in the pontine and midbrain junction. The locus coeruleus, which regulate the muscle tone during the sleep. During the sleep, activation of these extrapyramidal inhibition of the extrapyramidal descending tract, that is ideally done by the locus coeruleus, that will leads to atonia in a normal person. In a case of degenerative disorders like Parkinson's disease, due to accumulation of the synucleinopathy, accumulation of the synuclein protein in the locus coeruleus, that will leads to exaggerated response of the extrapyramidal descending pathways, that will lead to increase in the tone in the REM sleep. So increase in the tone in the REM, that will leads to activation of the motor activity. So patients start having kicking movements or dream enactment behavior. Patients started doing violent activities. So this is called REM, sleep behavioral disorder. This is very classical of synucleinopathies. It indirectly indicate in future patient will develop degenerative diseases secondary to accumulation of the synuclein protein. So whenever you are taking the sleep history in a movement disorders, you should always ask REM, sleep behavior disorder. If you have any doubt, you can ask now only. It is very important. So whenever taking the sleep history in any movement disorders or any dementia patients, you need to ask REMBD. Any doubts in this REMBD?
No, sir.
No, okay. Let us come to asterixis, your favorite examination finding in CLD patient. Is also called the liver plaque, but not only seen in liver diseases, you can see in many metabolic encephalitis. In case of metabolic encephalopathy, like in end-stage renal failure, end-stage cardiac failure, and severe metabolic disturbance, also you will get asterixis. It is defined as inability to sustain normal muscle tone. Okay, with the arms outstretched and the wrist extended, stopping tropic, the lapse in the postural tone that causes the hands to suddenly flop downwards, then quickly recover, causing a slow and irregular flopping motion. The terminology named as liver flap. So sometimes entire arm may drop. So you can see in lower limb also, if, keeping the patient foot in a dorsiflex position, that time also you can see foot flap. And unilateral asterixis usually seen in the lesions that are involving the thalamus. Okay. Sometimes in metabolic encephalopathy, there may be high frequency postural tremor that begins after latent period of 2 to 30 seconds and attenuates on movement. This is called mini asterixis. Here only predominant tremor like symptoms will be there. This is also called metabolic tremor, as all of you might have seen in the medical ICU wards. Okay. In lower limbs, you can examine the asterixis by keeping the hip in slightly flex and abducting the hips. So in that position, patient knee may flap up and down. That will also, in that way also, you can demonstrate the asterix in lower limb. So only upper, you don't see only in upper limb. So you see in a put dorsiflex position, or you can see in a by placing the hip in a flexing and abducting manner in the shape of V shape. Okay, in that setting also you can see the asterixis. So next one is painful moving toes and fingers. This is due to the activation of continuous flexion and extension movement, predominantly involving the limbs. The classical features will be patient having severe pain whenever doing movement or at rest position also. So most oftenly we see in the severe peripheral neuropathy conditions. Okay. This leg pain will be much troublesome. Patient will have constant movement in this painful moving toes and leg. Let us come to the myoclonus. This is a brief, jerky, shock-like involuntary movement. It may be caused by muscular abnormal muscle contraction, that is called positive myoclonus, or inhibition like negative myoclonus. Like examples would be Asterixis. Myoclonus is most oftenly irregular. Sometimes you can see in a regular myoclonus in a setting of palatal. One entity is the palatal myoclonus. Only in that setting you see rhythmic myoclonus. Rest other all myoclonic sacs would be non-rhythmic or arrhythmic. Okay? So come to the approach to the myoclonus. As all of you know, negative myoclonus, there is asterixis. You need to rule out by doing proper clinical examination. If you find that patient is having positive myoclonus, you can see in physiological conditions like physiological hypnics, hiccups, benign neonatal myoclonus, or whenever patient started sleeping, that time also will have myoclonus. That all come under the physiological myoclonus. In pathological myoclonus, it may be secondary to involvement of the cerebral cortex or subcortical structures like basal ganglia or brainstem or spinal cord involvement. In a cortical myoclonus, patient will have most oftenly focal or multifocal myoclonus. Most of the cortical myoclonus will have sensory or touch stimulation will trigger the movement. Okay, so classical examples will be epilepsia partialis continua, that is focal status epilepticus. That's also called cortical myoclonus. In a subcortical myoclonus, uh, patient will have like generalized caudal to rostral spread will be there. Generalized myoclonus will be there, involving both proximal and distal. Most oftenly, these myoclonus will be triggered by sound. Okay, these are the some clinical features which helps to differentiate from myoclonus origin. Okay, in cortical patient will have touch stimulus sensitive myoclonus will be there. Most of the time asymmetrical, focal, distal involvement. In subcortical, symmetrical, proximal and distal, and sound sensitive myoclonus will be there. Spinal, like level of involvement of spinal cord, that will causes according to the jerky movements involving the limbs. So basic approach to the myoclonus, just you confirm whether the patient is having myoclonus or not by detailed history and examination. And you need to localize anatomically whether patient is having cortical myoclonus or subcortical myoclonus or spinal cord. It can be confirmed by electrophysiological testing. Electrophysiological testing would not be much beneficial for you people. Usually in electrophysiological testing, if you do electrophysiological test, there will be burst of less than 100 milliseconds wave will be there in cortical, but in more than 100 millisecond burst will be there in subcortical myoclonus. Once you confirm once you confirm the localization of the myoclonus, you need to evaluate for the causes. Okay, if, you need to ask the history for any medicine overuse or any history of toxin agents. So that if patient is having that kind of history, so you can evaluate accordingly. If patient is having spinal cord symptoms like paraplegia, urinary symptoms, sensory findings, in that you can evaluate accordingly. Okay, if needed, you can get MRI spine if patient is having only spinal myoclonus. So basic laboratory, all the metabolic parameters should be ruled. Any patient of tremor or myoclonus, dystonia, okay, you need to rule out basic all metabolic parameters like electrolytes, urea creatinine, liver function test, ammonia level, thyroid function test. All these metabolic parameters to be ruled out in all the setting of movement disorders. Okay, all because all these are reversible condition. So once metabolic conditions are ruled out, you can order for imaging to look for any focal lesions. If focal lesions is not there, again you need to see for other causes like mitochondrial or any neurodegenerative disorders. If you're suspecting mitochondrial or neurodegenerative disorders, you can order for genetic testing. Okay. So let us come to the myokymia and cyanosis. Myokymia is fine, persistent, curing or rippling movement of the muscle, sometimes called live flashed by the patient. Most commonly we see pontine lesions like multiple sclerosis that is affecting the pons, especially facial nucleus. And in case of pontine glioma also we can see. And other entity is synkinesia. Synkinesia is like aberrant reinnervation that is co-activating the multiple parts of the same innervated muscles of the nerve. Say for an example, post Bell's palsy, if a patient wants to move the orbicularis oris to one side, meanwhile patient orbicularis oculi also get activated. So whenever patient try to smile, eye closure will occur. That is called synkinetic movement. This is mainly secondary to the aberrant reinnervation. Next one is myoarrhythmia. These are all the these are also like tremors only, but slow rhythmic movements will be there. Most commonly it is bilateral. Predominantly, it affects the orofacial masticatory muscles, and frequency would be less than 3 Hz. So classically, we see in Whipple's disease. This is called oculofacial-masticatory myoarrhythmia. This is very classical and the diagnostic of Whipple disease. We'll show you the video. Okay, patient will be having slow moving, repetitive, synchronous, rhythmic contraction that are involving the ocular facial masticatory muscles. Okay, myoarrhythmia is very classical of Whipple disease and the diagnostic finding in Whipple disease. If patient is having ocular masticatory myoarrhythmia, you should rule out Whipple. Okay, very rarely other causes like phenytoin toxicity sometimes causes myoarrhythmia, but Whipple is very classical. Okay, let's come to the paroxysmal dyskinesia, in which patient will be having paroxysmal symptoms. And dyskinesia, as all of you know, is a mixture of movement, chorea, tetosis, dystonia, and a single patient, that is called dyskinesia. Paroxysmal means it used to occur paroxysmally, sometimes seconds, sometimes minutes, sometimes hours. In between the attack, patient will be normal. Again, it is classified as kinesogenic and non-kinesogenic. In kinesogenic, patient will have triggers like sudden movement. In non-kinesogenic, patient will have any triggering movement like tea, coffee, fatigue might precipitate the movement. This is called non-kinesogenic dyskinesias. Okay, these are treatable entities. So most commonly secondary to channel mutations like PRPT, sodium channel mutations will causes these kind of movements. Simple sodium channel blockers like phenytoin, carbamazepine completely abolish these paroxysmal dyskinesia. So if you identify these movement rather than telling that patient is having psychological movement disorder, psychiatric psychogenic movement disorder, you need to see whether it is PKD or PNKD. So because both these two are treatable conditions. Next, come to the stereotypy. This is a non-goal directed, repetitive, rhythmic movement. Most commonly, these movements will be distracted. So if you give the touch stimulus, if you give the sound stimulus, most often these movements will distracted and sometimes it may stop. So it will help you to differentiate from the motor tics and other movement disorders. Okay, we'll see the videos in the after completion of our PPT. Next slide. Come to the tics. These are the abnormal movements. Like you can classify tics as motor tics and phonic tics. Most commonly we see in Gilles-de la Tourette syndrome. Like patient will having most commonly sensory urge and suppressibility features. Like akathetic movement, tics are usually preceded by uncomfortable feeling or sensory urge to move, like scratching and itch. This movement sounds to be called as involuntary rather than voluntary or involuntary. The mixed term. Sometimes patient have voluntary or sometimes patient have involuntary movement. So better terminology would be involuntary for tics. Sometimes in if a patient start to suppress this movement, anxiety will build up and patient will again start the movement. So how to differentiate from the other movement disorder in which patient will have sensory urge and after doing this movement, after doing movement, this movement, patient will be relaxed. But in akathisia, patient condition as if like patient will be having inner restlessness phase. But in a sensory, in a tic patient will not have any restlessness features. Like whenever doing the movement, during that time only patient will be restless. But in akathisia, patient will be continuously restless. These few points will help you to differentiate from akathisia from the motor or akathisia from the tics. Okay. So tics most commonly we see physiological tics like as like her own patient persons will have their own styles like talking, walking, gait, all those things all come under the physiological tics like called mannerism. In pathological tics, most commonly secondary causes like Tourette syndrome, encephalitis, syndrome choreas, drugs, carbon monoxide poisoning, developmental delays, cerebral palsies, head trauma, all will also causes tics. In a primary idiopathic or genetic pathological tics, you can see transiently in the infant, or sometimes you can see in sometimes most of the Tourette patients will have Tourette syndrome patient will have tics, in which the motor tics also there, phonic tics will also be there. And other causes like Wilson's disease, tuberous sclerosis, Huntington disease, acanthocytosis, Haloviden's disease will also have tics. Okay, according to the clinical history examination, we can evaluate the patient based on these etiological agents. Next, so we'll come to the tremor. This is a oscillatory movement, rhythmic, regular, leads the to and fro movement of the one part or more body parts. Okay, most commonly due to the alternating contraction of agonist and antagonist movements. These tremors will occur in myoclonus or dystonia also, but dystonic tremors will be very irregular, and myoclonic tremors will have jerky component, like rate, location, amplitude, and constantly vary depending on the specific type of the tremor. Okay, we'll discuss the tremor. So tremors basically classified as rest tremor, postural tremors, action tremors, and intention tremor. Tremors is like broad classification under which postural and kinetic tremors will come. Most commonly, rest tremors we see in the Parkinsonism. Postural tremors, that is action tremors, we oftenly see in essential tremor, and intentional tremor will be seen in cerebellar diseases or cerebellar outflow pathway. And the one entity is called rubral or midbrain tremors, in which patient will having tremors in the all the, like patient will be having rest tremors, postural tremors, and intention tremor. That is called Holmes tremor or rubral tremor. Okay, we'll see the videos next. See, first you classify the tremor patient whether having rest tremor or action tremor. In action tremor, we can classify the kinetic tremor, postural tremor, and isometric tremor. Isometric tremors are nothing but when you are doing the isometric movements. Say, for example, while you are pushing the wall, that is called isometric tremor. In kinetic tremor, again classified as simple kinetic, intentional, and task specific. Simple kinetic tremors like doing activities as the movement go on progresses all throughout the range of movement, patient will be having tremor as you've seen in your essential tremor. Intention tremor, at the end of the movement, patient will be having tremors. That is intention tremor. Most commonly we see in cerebellar disease. Task specific kinetic tremors means that is only pertaining to the particular task, like whenever writing, when we're using the violin, that kind of only task specific. These are task specific kinetic tremors. Postural, again, you can classify as postural dependent, or position dependent, non-position dependent, or position independent tremors. Okay. Next slide. So tremor syndrome, mainly you can tell as action tremors, rest tremors, focal tremors, task specific, orthostatic, associated additional signs, and other tremors. Most commonly, action tremors will be seen in essential tremors, segmental tremors, isolated rest tremors, and enhanced physiological tremors. All will come under action tremor. In a focal tremors like voice tremors, head tremors, jaw tremors, voice tremors and head tremors most commonly we see in essential tremors. Jaw tremors we see in Parkinson's disease, and palatal tremors. Sometimes task position specific tremors like writing, sports, activities, musicians will have task specific tremor. Orthostatic tremor are nothing but when a patient stands on the ground, that time tremors used to develop in the lower limb. That is called orthostatic tremor, and this disappears when a patient start walking or lying on the bed. And if a patient is having tremor along with the other movement disorder, like if a dystonia patient is having tremors, that is dystonic tremors, and Parkinsonism associated tremors, intention tremors in cerebellar disease, Holmes tremor in midbrain disease, myoarrhythmias as in Whipple's disease, and palatal tremors, and other like functional tremors also entity exist. These are all the broad tremor syndrome classification. Just you see what kind of tremor patient is having. Say, for example, if a patient is having rest tremor, most commonly it is Parkinsonian tremor. In essential tremor, we see, but later stage or end stage of essential tremors, we can see rest tremor. And midbrain, that is Holmes tremor also will have rest tremor. Myoarrhythmia also present in rest. These are, if a patient is having only rest tremor, you can see in Parkinson's, midbrain, rubral tumors, or myoarrhythmias. Okay. Postural tremors, most commonly we see in physiological tremors, enhanced physiological tremor, that is stress, endocrine disease, drugs, toxins, that also causes enhancement of physiological tremors. Essential tremor, orthostatic tremor. Parkinson's disease, another patient, whenever you tell the patient to outstretch the arm, within 10 seconds of outstretching the arm, patient will start having the tremors. That is called re-emergent tremors. Dystonic tremors, cerebellar tremors, myoarrhythmias, cortical tremors will also having postural tremors. Okay. In kinetic, most commonly intentional tremor we see in the cerebellum, and these rubral tremor, that midbrain tremor will also have kinetic component. Other tremors will be psychological or idiopathic tremors. Okay, just you remember the causes of rest tremors, postural tremors, and kinetic tremors. At least two examples for each kind of tremors. Okay. Most of the time in a dystonic tremor, patient will be having sensory tricks, abnormal posturing, and null points will be there. Null point means nothing but where exactly sometime in a particular position the dystonic movement completely disappears. That is called null point. This is classical of dystonia. Null point and the sensory tricks are most classical of dystonia. So patient will be having abnormal posturing, sensory tricks, null point associated with the tremor. The tremor that too will be having jerky component and irregular tremors will be there. Physiological, as all of you see, fine tremor that are involving the distal extremities. Neuropathic tremor most commonly associated with neuropathic symptoms like tingling, paresthesia, pseudoathetosis, along with the tremors. Parkinson's tremor most commonly we see rest and sometime on posture that are called re-emergent Parkinson's tremor. And genetic disorders like fragile associated tremor syndrome, but in this setting, patient will be having ataxia and Parkinson's symptom. Home tremors, that is called rubral tremor or midbrain tremor, in which patient will be having tremors in all the position like rest, action, and kinetic movements also causes home tremor. Drug-induced tremor, again, it most commonly we see with the sodium valproate, thyroxine, salbutamol nebulization that also causes tremors. Most commonly these are fine tremors. Okay, functional tremors, patient will have abrupt history of onset, spontaneous remission. There will be distractibility, variability, entrainment will also be there. Okay. Let's come to the fasciculation. Most commonly you see in OP compound poisoning and motor neuron disease. These are the fine, rapid, flickering or vermicular movement due to the contraction of bundle or fasciculus of the muscle fiber. That is called fasciculation. Fibrillation is only single muscle fiber that can be demonstrated in the electromyography. Visibly, whatever we are seeing is fasciculation. This is the bundle or fasciculus of muscle fiber, and fibrillation is only single muscle fiber that can be demonstrated in the electromyography. So it will not displaces the joint, but sometimes it will causes the movement of the distal digit. That is called polymini myoclonus. Polymini myoclonus classically seen in amyotrophic lateral sclerosis. Okay, multiple vesicles will get activated, leads to the distal movement. Okay, so these are all the random, irregular, fleeting movement, may spread from one place to another place, may affect multiple various sites. Okay. So whenever you see the fasciculation, don't only tell this is the anti-Horn cell disease. So other causes for fasciculations are spinal muscular atrophy, radiculopathies, post-radiation, CIDP, hypocalcemia, compressive nerve injuries, OP compound poisoning, thyrotoxicosis, and peripheral hyperexcitability syndromes like Moore-1 syndrome, all will causes fasciculation. Okay, so whenever if your patient is having fasciculation, don't put into only ALS spectrum. So you need to rule out all these causes also depending on history and examination. So last one is psychogenic movement disorders. It can mimic any kind of movement disorders. The classical 3 points that will help you to differentiate from other movement disorders is, one is distractibility. Whenever you are examining the patient of any movement, hypo or hyperkinetic, you need to give multiple tasks to the patient. Say for an example, if a patient is having cervical dystonia, you are suspecting patient is having functional component. You need to tell the patient, like you have to give the multiple tasks. You have to tell the patient to walk on toes, and meanwhile you have to tell the patient to close and open the eyes and tapping of the finger. So if you give 2 or 3 tasks at a time, the dystonia will disappear. This is the distractibility. You can distract the patient movement by giving the multiple tasks. This is the classical feature of psychogenic movement disorder. And second one is variability. Variability means patient will be having sometime involvement of the upper limb, lower limb, dystonic movement, chorea movement. So there will be multiple variable according to the time frame. If a patient is having movement disorder, so you can tell us patient is having movement disorder. This is called variability. And third one is entrainment. Like if you give the task to the non-affected part, say for an example, if a patient is having tremors in the right upper limb, if you thought to be secondary to functional, just you do movement on the left upper limb wrist, to and fro movement of the left upper limb, patient will start moving the left upper limb similar to the right upper limb. So you can entrain the movement. That is called entrainment. So if a patient is having distractibility, variability, and entrainment, this is classical of psychogenic movement disorder. So all the movement disorders, before you are labeling, you need to check these three, because if you identify these, no need to do for any further investigation. Just counseling and psychiatric referral would help them a lot. Okay, don't forget to see for distractibility, variability, and entrainment in a functional movement disorder. Okay, and in this functional movement disorder, patient will having multiple psychosomatic symptoms, schizophrenia, all those things, associated psychiatric symptoms will also be there. So okay, when to evaluate the patient? So sometimes autoimmune diseases like autoimmune encephalitis due to the anti-LGI1 antibodies, anti-Caspar-2 antibodies, NMDR encephalitis, aquaporin 4 antibodies that do causes movement disorders. So you should not miss. Most often, just you remember the antibodies, don't go through in detail. In a anti-LGI1 autoimmune encephalitis, patient will have dystonic movement that is involving the face muscles and the upper limbs, facial-brachial seizures. And myoclonus will be I'm sorry, it is not myoclonus, it is myokimias will be seen in anti-Caspar associated antibodies. And in orofacial dyskinesis, most commonly we see in NMDR encephalitis. And abnormal perioral movements which are seen in the anti-GLON5 antibody associated movement disorders. And NMOSD, NMO Morg spectrum disorder, that will also causes tonic spasm that are involving the most commonly we see in the lower limbs. So these movements are like very treatable condition. So if you have these kind of symptoms in your patient, you need to evaluate for autoimmune causes of the movement disorders. Okay. So hyponatremia is also classical of LGI1 encephalitis, and sleep disorders, breathing disorders, Parkinsonism is IGLAN5 antibodies. If a patient is having long-standing diarrhea with movement disorders like anti-DPPX antibody associated autoimmune encephalitis, if a patient is having meningitis features, headache, blurred vision, anti-GFAP antibody associated movement disorder. If a patient previously affected herpes simplex encephalitis, now turned to be NMDR encephalitis, in that also you will be having orofacial dyskinesias. If any abnormal finding in the CSF or MRI or EEG, and a patient having any history of malignancy, these are very potential treatable subacute onset movement disorders. Okay, in this setting you need to evaluate aggressively. Next, so basic investigation. So here in this picture, A connotes akinetic rigid syndrome, C is chorea, B is Bellism, D is dystonia, T is tics, M is myoclonus. Okay, A, C, B, D, T, M. So you identify the movement disorder, you evaluate accordingly. If a patient is having akinetic rigid syndrome or Parkinson's disease, you need to evaluate what are these plus marks that are mentioned here. You need to evaluate. So routinely we use complete hematological investigations, calcium profile, liver profile, copper profile, slit lamp examination for Wells KF ring, thyroid functions, ASLO titer in rheumatic choreas, ANA, acanthocytes in chorea, lysosomal storage disorders, organoamino acidureas in a case of pediatric age group, genetic studies, bone marrow studies for storage cells, electron microscopy, nerve muscle biopsy in mitochondrial inheritance disorders, OCBs, if needed, MRI or PET scan, EEG studies, EMG studies, particularly to differentiate the myoclonus, evoked potential, retinogram, and neuropsychological testing. First, you identify the what motor movement patient is having, then you evaluate accordingly. These are the basic investigations which are done in the particular group of movement disorders. Okay, just you go through the table in the later half of the class. Okay? So as the below mentioned, these are the very potential causes for to reverse the movement disorders. Okay, the main treatable metabolic hyperkinetic movement disorders. So always you rule out if a tremor patient comes, just you don't label as essential tremor and send back. So in a tremor patient, at least you evaluate thyroid profile, hepatic panel, renal profile, magnesium, calcium, B12, homocysteine level, and brain MRI. So this is a mandatory investigation in a tremor patient. So if you get any mention these investigations positive, you can completely reverse the condition rather than putting propanol and all those things and sending patient the back. So evaluate any tremor patient. These are the list. Any chorea patient, sugars, polycythemia, liver profile, electrolytes, B12, thyroid, and imaging. In a case of myoclonus, again same, all metabolic parameters and electrolytes. And in a setting of paroxysmal disorders, paroxysmal kinestonic dyskinesia, you need to look for our metabolic parameters. So all the patient, those who come to your clinic with the whether it is hypo or hyperkalemic movement disorders, better you basic investigate. Basic investigations to be done always. Your CBC, RFT, LFT, serum electrolytes, B12, homocysteine. These are the basic routine investigations. Okay, all the patients in a movement disorder, better you evaluate. If you don't get any cause, that time you can give it symptomatically. A patient is affordable, you can go ahead with the other investigation. So these are the basic investigation can be done in any hospitals. Okay. So these autoimmune drug-induced metabolic infectious causes most commonly treatable, and genetic causes like paroxysmal dyskinesia can also be treated. Okay. So treatable condition you try to identify. If you don't get treatable causes, then you can evaluate for the degenerative condition, hereditary condition, genetic causes. All those things will be evaluated in the subsequent visit. Okay. This is the same slide. Okay, you go through it and later part. Just you come to the treatment aspect. Just I have covered in a single page. Next slide. So dystonia, the drugs which are beneficial in the dystonia. First, always any movement disorder, rule out secondary causes, identify the cause, treat the cause. This is the first mandatory to all the movement disorders. If you don't get any cause, the drugs which are beneficial in the dystonia would be dopamine supplementation, anticholinergic drug, baclofen, tetrabenazine, anticonvulsant like carbamazepine, pregabalin, muscle relaxants, sodium oxybate, clozapine, and later part would be botulinum toxin. So these are all the drugs which are proven in a treatment of dystonia. So first you need to identify the cause, treat the underlying cause, then you go for the drugs. Okay. Next. Tremor, most commonly we see essential tremor in our clinical practice. Better you start with the propanol low dose after ruling out any bradyarrhythmias or any asthma or hyperactive airway diseases. You start with the propanol with the minimum dose 20 mg. BD or TDS dose, you can gradually escalate. You can give up to 240 mg. If patient having still tremors, you can add the primidone drug. Primidone can be started with 12.5 mg BD. You can gradually escalate. You can give up to 500 mg per day. So even after that, if the patient is having persistent essential tremor, you can add small dose of your benzodiazepine, gabapentin, or topiramate. Even after that, also patient not improving, you can plan for botulinum toxin or deep brain stimulation surgeries. Okay. Meanwhile, you need to rule out the causes for kinetic and postural tremors. Okay. After ruling out the other causes, you can start. Okay. So chorea, again, the cause to be addressed always. Once you ruled out the cause, if you don't get any causes, then you can give with the drugs trial like NMDR antagonists like amantadine, drugs like levetiracetam, valproic acid, carbamazepine, and the later part you can plan for deep brain stimulation. And some of the drugs, other drugs like atypical neuroleptics like haloperidol, tetrabenazine, reserpine can also have benefit in treatment of chorea. Next. Next would be myoclonus. Again, the funda is we treat the underlying cause, correct the metabolic parameter, and if everything come normal, you can try with valproate, pyracetam, levetiracetam, valproate, and clonazepam. These are the proven drug will help you to give symptomatic treatment in the myoclonus patient. So for the tics, you can give benzodiazepine, antipsychotics, and small dose of clonidine will also help. And if in case Gilles D Tourette syndrome, you can try with aripiprazole, risperidone, or tetrabenazine drugs also. So in conclusion, most commonly we see the cases in our clinical practice are akinesia, bradykinesia, tremors, dystonia, chorea, myoclonus, tics, stereotypic movement disorders, paroxysmal dyskinesias, ataxias, and dyskinesias. These are the common disorders you should be knowing. You should identify the movement and syndromic approach and evaluate the basic investigations and treat accordingly. Just will, if you have any doubt, you can ask now. After that, we can see the videos. Any doubts?
Sir, the localization of all this comes in basal ganglia.
Basal ganglia, again in basal ganglia, you can see for in putamen, like putamen lesions most often causes dystonia. Caudate will causes chorea. Substantia nigra compacta will cause Parkinson's. Most oftenly, you can, all these nucleus will come under basal ganglia circuit only. But tremors, myoclonus, tics, you cannot able to single localization will not be there for tremor, myoclonus, and tics. Okay, multiple localization will be there for that. For Balism, it is subthalamic nucleus.
Okay. Yeah, open. Come on.
Hello.
Sir, what are the drugs which cause movement disorders? What do we have to look for?
Okay, drugs most oftenly hypokinetic movement disorder most oftenly caused by dopamine blocking agents like antipsychotic drugs if you are giving gastrokinetic agents like levosulfuride, domperidone. These will causes dopamine depletion. So dopamine depletion that will leads to hypokinetic movement disorder. So whenever Parkinsonism patient comes, you ask for antipsychotics and these gastrokinetic agent. If a patient hyperkinetic movement disorders, if patient comes, most oftenly that will also caused by the antipsychotic drug. If a patient using for a long time, chronic long duration, if antipsychotics are given, that will causes receptor hypersensitivity. So that will leads to the hyperkinetic movement disorders. So these antipsychotic drugs will have dual edge, like a double edge knife. So short duration will cause us Parkinsonism, long duration will cause us tardive dyskinesias, chorias, all those things. And sometimes anti-epileptic drugs like phenytoin and carbamazepine will also cause us hyperkinetic movement disorders. So anti-epileptic, antipsychotic, gastrokinetic drugs, you have to evaluate in all movement disorders.
So, sir, immediately after we stop the drug, it will reverse back?
No, depending on involvement. Like if a basal ganglia circuitry is affected strongly, sometimes your hyperkinetic movement disorders will not disappear. It may persist lifelong, depending on what level the basal ganglia circuit has been damaged. Sometimes patient will have lifetime adverse events, especially this tardive dyskinesias, drug-induced hyperkinetic movement disorder. Second to antipsychotic, if they use for a long time, this says if they use more than a period of 6 months, sometimes in a patient, it may persist for lifetime, not completely curable.
Sir, even post-encephalitis, this can happen, sir?
Post-encephalitis?
Dystonias can occur, sir?
Yes, it can occur. If encephalitis, most commonly the arbovirus like JE, dengue, chikungunya will affect basal ganglia. Predominantly, these viruses will affect basal ganglia circuit. So most commonly post JE sequelae will get Parkinson's, post-infectious Parkinson. And I think 10 years back, the influenza patient, like influenza strain, I'm not remembering the exact. Post-influenza also multiple patients had developed Parkinson. Encephalitis phygalistica, that one entity is there, no? Post-infectious Parkinson's. First time it was discovered in influenza, but commonly we see in post-arboviral infection, especially JE, Japanese encephalitis.
Okay, sir.
Any other doubts?
There are
Sir, sensory flicks, can you explain again, sir? That we didn't understand.
Sensory tricks?
Sir, that we didn't understand, sir. Can you explain it again, sir?
Okay. Say for example, patient is having cervical dystonia, lateral flexion of the neck. Okay. Some of the patient will use the hand to make the head straight. So lateral colis, patient is having lateral colis, just take the hand support and put the hand on the chin and make the head in the straight manner. So that will also help the patient to get rid of movement disorders. That is called sensory trick. Any sensory or any sensory stimulus or any hand movements that disappears the movement disorder. This is called sensory tricks, geste antagonist. Just taking the hand support to abort the movement, or any cutaneous stimulation to abort the movement.
Okay, sir.
In that picture, I think two pictures I have shown. In that picture, that elderly female having cervical dystonia, just she put her hands just below the chin to prevent that dystonia. That is called sensory tics.
okay.
Also called prayer mentis sign also. Prayer mentis sign.
Sir, that's all, sir.
Okay, we'll see the videos. Samir, you have selected the important videos.
Yes, sir. Yes. I'll play some.
You just play. Just I will explain.
Okay,
If
sir.
you have any doubts, you can stop in between and we can discuss. Okay. We'll
Okay.
start the videos. We'll finish it.
2 minutes.
Okay. No.
Sir, one video is over.
Started.
Sir, I'll play it again, sir.
You play it. Okay. This is a typical Parkinson's disease. Here you can see the rest tremors in the right hand and pill rolling tremors also. And walking also, there is gross asymmetry. It is present only on the right side. Resting tremor in the right upper limb in an elderly patient is almost Parkinson's. Okay. Next.
Next video.
Next video. Okay. Just here you see patient is having cervical dystonia, right articulis. The you see that tremors. Patient is having like jerky movements are there. There are irregular movements. As in Parkinson's disease, there is regular rhythmic movements are there. Here, the jerk-like abnormal movement is there and very irregular. Okay, you can classically see in dystonia. So these are called dystonic tremors. You can see left upper limb rest tremors. Whenever you are stretching the hand, the tremors will start appearing immediately within less than 10 seconds. These are all called re-emergent tremors. Usually postural tremors will start appear after 10 seconds. Okay, these are the re-emergent Parkinson's tremor. This is also classical of idiopathic Parkinson's disease. Hemiplegism predominantly due to involvement of the subthalamic nucleus. It may be secondary to non-ketotic hyperglycemia, toxoplasmosis, vascular malformation, syndrome scoria, sometimes structural lesions involving the subthalamic nucleus. You are seeing left upper limb, lower limb, predominantly proximal movements are there. These are like flinging movement, kicking movements. Okay, left upper limb and lower limb. Very violent movement. Sometimes patient may harm the surrounding and self also. Due to his abnormal contraction, patient have rhabdomyolysis, aka acute kidney injury will also occur. So you need to address it on urgent basis to prevent the complications. Chorea in a young patient, you need to rule out syndrome, lupus, Aplas syndrome, okay, polycythemia. So here is the diagnosed case of lupus with encephalopathy, chorea involving the tongue, jack in the tongue phenomena, bilateral upper limbs after treatment with steroids and tetrabenazine. Tetrabenazine is VMAT inhibitor that will replenish the dopamine, will be much beneficial in the chorea patients. Okay. Vesicular monoamino uptake inhibitor, VMAT. This is a diagnosed case of Huntington's. You see the chorea movements which are affecting predominantly head and neck region, bilateral upper limb and lower limbs also. Here they are checking saccades. Usually saccades are affected in chorea. Patient will have slow saccade, and sometimes patient will turn the head to see the objects without like turning the eyeballs, involving the tongue, the chorea that is involving the tongue. That is the milkmaid grip. Okay, it's classical of chorea. You see the case. Sometimes patient tries to hold the opposite limb, that is called parakinesis. Chorea patient try to hold the opposite limbs or the choreatic hands, okay, to prevent the movement. That is called parakinesia. In this picture, you can see. This is again one more case of dystonia. DYT is like genetic dystonia. DYT gene, they're all genes, okay. You see holding how he is holding the pen. Abnormal flexion that are involving the metacarpophalangeal joints. This is the right upper limb.
Good.
Dystonic posturing.
And then put your hands like that. Good. Now put your hands just over your head. A bit higher. Good. Put your hands out in front of you like that. And now can you do the open and close?
Some Parkinson's features. Right side there is some slowness.
Another 1, 2, 3, 4. and that one.
There's also one more video of Korea. Huntington predominantly affect orofacial muscles compared to limb muscles. The reason that the terminology is removed, retinal chorea is not nowadays used. Okay, it's a proven case of Huntington, as they're saying. Like Wilson's disease, predominantly younger age group involving the oromandibular dystonia.
When did this problem first begin?
When he was 12 years old.
And what was it that happened then?
First things that started noticing, he couldn't walk across the room without stumbling over his own feet.
Did that come on all of a sudden or sort of gradually develop?
Gradually. Before that, he did everything at the normal rate, ride a bicycle, rode a tricycle, ran around, got in trouble just like the average person.
So everything was just fine until
Correct.
about the age of 12.
Right.
And that's when this difficulty walking began.
He was diagnosed at age 12, and he got on the cupramine. It was diagnosed the right amount for his weight and everything, and started. He took it for a couple of years. Then as he got
Did things
into
improve
teen,
during those couple of years?
No.
Okay.
We could not tell that they did. Definitely not the school. The social, the peer group pressure was bad. It didn't work out at school at all. He never finished school because of this. He went
Was there ever any tremor or flapping movements?
with his arms, not
Yeah.
his legs.
What-
Definitely his arms.
What would they do?
It was like he couldn't control them, and they would stiffen up, and a lot of times they would, his right arm especially would go behind him. Many times we've had to pull
As
his
tightly
arm
as you
down.
can. Squeeze them shut. Good. Open your eyes.
Leprospasm, oromandibular
Now
dystonia.
you're trying to open them, but they just won't open up on you, huh?
Jaw opening dystonia.
Okay. Can you stick your tongue out? Can you wiggle it from side to side? Okay. Are you able to make any sounds? Now I might add while we're doing the exam that cognitive function is very good. With the computer, plays computer games, understands everything very well.
So any young patient, it is dictum, any young patient with dystonia, always rule out Wilson. Okay, this is the athetosis involving the distal writhing movement, predominantly involve the hand and fingers. Okay, predominantly seen in basal ganglia lesion. Initially it was described in kernicterus. Okay, so any basal ganglia structural lesions that will causes athetosis, writhing slow movements.
बताइए दिक्कत के बारे में बताइए।
Elderly patient
यही सबसे बड़ा है
having voice tremors and head tremors.
हाँ,
It is a case of essential tremor.
कोई काम कर नहीं
It was
पाते,
taken during my
खाना भी
residency.
नहीं, पानी भी नहीं,
नहीं खा
कुछ
सकते।
भी नहीं ले पाते।
ठीक। मुंह खोलिए, मुंह खोलिए, हल्का सा खोलिए मुंह। हाथ सीधा करिए। हाथ सीधा करिए, सीधा ऐसे कर, ऐसे करिए.
You can post this individual video in group. I think it is not playing very nicely. Okay, no problem. This is a left hemifacial spasm involving the orbicularis oris, aquilae, buccinator, forehead frontalis contraction also there. Okay, you need to rule out any vascular loop that is compressing the facial nerve. So always get MRI brain with seventh nerve cis sequence along with the angiography to rule out any vascular loop. Okay, only proven treatment would be botulinum toxin. If any abnormal structure is there, you can do microvascular decompression surgery. Okay, drugs are not much beneficial in hemifacial spasm. This is a classical of acylomasticatory myoarrhythmia. You see the jaw having rhythmic, slow, regular movements along with the involvement of eyeball. That is rhythmic inward movement of the eyeballs, jaw contraction. This is a classical of Whipple disease. Is also called acylomasticatory myoarrhythmia. This was the proven case of
सीधा
SSP
देखो,
with
सीधा सीधा देखने के लिए कोशिश करो.
myoclonic jaw. Having horizontal gaze nystagmus. I think his walking video would be much beneficial for you people. He was having myoclonic jaws involving the upper limb, lower limb, and the trunk. He used to fall whenever he start walking. Just you say the gate, suddenly he will have myoclonic jaw. You see
आइए,
that the
वापस
jaw.
आइए, वापस आइए.
This was also taken in my residency time. So proven case of SSP.
खड़े हो जाओ.
You see there, one more jerk. Okay. This is a case of myokymia, that is rippling movement of the top muscles. This is diagnosed case of Casper-2 antibody-mediated autoimmune encephalitis. This is also called Moore-1 syndrome. Okay. Recently, we saw this case in our hospital. This is classical of myokymia. This is myotonia, abnormal contraction of the muscles, and there will be delayed relaxation. Okay, you see the muscles how it is hypertrophied quadriceps.
दर्द हो रहा है.
This is diagnosed case of Schwartz-Jampel syndrome. Patient had neuromyotonia involving all the parts of the body, along with the symptoms of palpitation, sweating, and neuropathy.
दूसरा पैर
also
मोड़िए,
there.
मोड़ के रखिए.
This is due to abnormal firing of the motor unit.
ठीक है, हाथ सीधा करिए ऐसा.
See his biceps, triceps, delta contracting spontaneously. These patients will have much better benefit with the sodium channel blockers like phenytoin, carbamazepine, and mexiletine. He was started with carbamazepine, it was improved. This is percussion myotonia. You see, it's a diagnosed case of myotonic dystrophy. One of my friends sent. This is the pseudoathetosis, diagnosed case of a sensory ganglionopathy. Just you see the fingers movement.
ಮರ್ಚಿ ಪೂರ್ತಿ ಮರ್ಚಿ ಹಿಂಗೆ ಹಂಗೆ ಸ್ವಲ್ಪ ತಿಟ್ಕೊಂಡಿರಿ, ಹಿಂಗೆ ಹಿಂಗೆ ಬಿಡ್ರಿ, ಲೂಸ್ ಬಿಡ್ರಿ.
And closure of the eyes, that is to working.
ಇಷ್ಟು ಮಟ್ಟಿಗೆ ಇರಲಿ, ಹಂಗೆ ಇರಲಿ. ನಿಮ್ಗೆ ಹೆಂಗೆ ತೊಂದರೆ ಆದ್ರೂ ಪರವಾಗಿಲ್ಲ, ಇಟ್ಕೊಳ್ಳಿ, ಮೇಲೆ ಇಟ್ಕೊ. ನಡ್ಗುತ್ತಾ?
And closure of the eyes, she used to fall down from the bed. She was having severe sensory ataxia, diagnosed case of sensory ganglionopathy. This is a young male patient having abnormal movement. These are all, he was having urge to move the movement and he could able to suppress the movement also. And after moving these, after a movement, patient used to have feeling relaxed. Okay, these are multifocal motor tics involving the neck muscles and the left shoulder. This is a case of Gilles de Tourette syndrome. You see.
ಕೈ ಸೀದಾ ಹಿಡ್ಕೊ, ಈ ಥರ ಸೀದಾ ಮಾಡಿ ಕೈ ಎರಡು. ಈ ಥರ ಮಾಡ್ತೀರಿ ಹಿಂಗೆ. ಹೆಸರೇನು ನಿಂದು? ಮಾಡ್ತೀರ ನೀನು? ಎಲ್ಲಿ ಓದ್ತಾ ಇದೆಯಾ?
Usually, to rule out the functional movement disorders, you can give multiple tasks. So even giving the task also, you used to do those abnormal movements.
ಏನು ಕೆಲಸ ಮಾಡ್ತಾರ ಅವರು? ಅಮ್ಮ ಏನು ಮಾಡ್ತಾರ? ಮನೆಗಿರ್ತಾರ. ನೀನು ಶಾಲೆಯಲ್ಲಿ ಚೆನ್ನಾಗಿ ಓದ್ತೀಯಾ? ಎಷ್ಟನೇ ಕ್ಲಾಸು? ಕೊನೆಗೆ ಎಕ್ಸಾಮ್ ಯಾವಾಗಾಗಿತ್ತು? ಎಕ್ಸಾಮ್ ಯಾವಾಗಾಗಿತ್ತು ಕೊನೆಗೆ? ಮಾರ್ಚಲ್ಲಿ. ಎಷ್ಟು ಮಾರ್ಕ್ಸ್ ತೆಗೆದೈತಿ? ಮಾರ್ಕ್ಸ್ ಎಷ್ಟು ತೆಗೆದೈತಿ? ಎಷ್ಟಕ್ಕೆ? 40ಕ್ಕೆ 30 ತೆಗೆದೈತೆ. ಒಂದೇ ಎಷ್ಟಿದ್ವು ಪೇಪರ್ ನಿನಗೆ? 43. ಬಿಡು, ಕೈ ಬಿಡು, ಕೇಳು.
So the tongue fasciculations you can see in motor disease, motor neuron diseases, and tongue is also atrophied. This is percussion myotonia, case of myotonic dystrophy involving the tongue. You see, after percussion, the tongue, there is inability to relax the contracted muscle. That is called myotonia. This is a case of myotonic dystrophy.
Sir, that's all, sir.
Over. Okay. Any doubts?
Sir, what are rubral tremors?
What?
Sir, rubral tremors?
Rubral tremor is like midbrain. You have rubral nucleus is there. You know, right? Rubral nucleus is there. Involvement of that, it will causes tremors in both rest, posture, and during the movement also. So all the kind of tremors will be present in a single person. That is called rubral tremor.
Okay, sir.
Samir, you have not put that video. Midbrain tremor was also there. I had given to you. Just you post in the group, okay? Patient will be having rest tremor, postural tremor, kinetic tremors. Okay, all the component in a single person. Another folder, I think.
Just a second, sir. I'll try to.
Video 1, video 2 is there. Video 1 folder it is there, I think. Rubral nucleus, that is red nucleus. Okay, red nucleus pathology will causes all the kind of tumors. This is also called dentatothalamic rubral outflow tract tremors.
So any specific disease?
Hello.
Sir, any specific disease that causes rubral tremors?
Usually any structural lesion, sometimes tuberculomas, toxoplasmosis, sarcosis that are infiltrating that red nucleus will causes. Most of the time structural lesions, any malignancies.
Okay, sir.
Most of the time we had seen in tuberculoma, 2-3 cases, midbrain tuberculoma, we had seen Holmes tremor, rubral tremor, or midbrain tremor. All these three terminals are similar. Now you see this video. You see right hand she is having rest tremors also. You notice the rest tremor first. This is rest tremor. Only in the right hand you are seeing. This is postural, okay, and wing beating position, postural tremor, and this is intentional tremor also patient is having, and kinetic also. Whenever she is moving also having tremor, and whenever she touching the finger also she is having tremor, and outstretching hand in a wing beating position also she is having tremor, and intention and rest position also she is having. Okay, this is called Holmes tremor or rubral tremors or midbrain tremors. I think in Wilson's disease one video is there, wing beating tremor is there, just to show that also. Wing beating is nothing but tremors that are involving the proximal extremities.
Swelling in my ankle, in my abdomen.
You were about 15 years old.
Yeah, I was about 15. Well, figure y'all can figure that out. But I started swelling up real bad in my ankle. I went into the doctor's office, and that's more or less all that was affecting me at that time.
I'm going to stop you just right there. And you were put on some medication.
Yes.
And things went along pretty well for another 4 years or so, is that right?
Yes.
And then what started happening?
Left
Then
leg
I
tremor is
started
there.
drooling at the mouth real bad. My equilibrium was off. I had to go like this a whole bunch of times to be able to stand up. And couldn't talk at all. I mean, I couldn't say one word.
I think it is not wing beating tremor is not there in this video. I will share it. Any other videos we missed?
So wind beating is not there, sir.
Not there, it's not there. You can like see in the YouTube. Okay.
Okay, sir.
Any doubts in this session?
No, sir.
No. Okay. Next
Thank you,
class will take about history taking and general physical examination in movement disorders. Okay.
Okay.
Next Friday, like after 15 days we'll plan. Okay.
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 Thank you so
Okay.
much.